This is Dr. Madhuri from Team MDS CONQUER. We'll have a quick glance of radiology in this video. If you take this slide, here the force carrier particles are given. So important force carrier particles are gluon and W boson. Okay, they can ask you like which of the force carrier particles will help or mediate the weak interactions. Then the answer will be your W boson. And this W boson has also an other importance, that is beta decay. So the two important points regarding the W boson includes weak interactions and they are also associated with the beta decay. And if you take the gluon, they mediate the strong nuclear forces. Okay, the strong nuclear forces are mediated by gluon. And one more force carrier particle, that is Z boson. So this Z boson is it mediates the weak interaction. Okay, and this also associated with the neutrino scatter. So these are the important points you have to remember regarding the force carrier particles. So this is the electromagnetic spectrum given here. The important two things here are, one is the wavelength and one is the photon energy and frequency. So you have to remember 2 points here, that is wavelength and photon energy are inversely proportional, whereas photon energy and frequency are directly proportional. So if you see the waves here, the radio waves will have a least amount of frequency, but if you take the gamma rays, they have a more amount of photon energy or frequency. So they can ask you the questions like which of the following waves will have a highest wavelength or lowest wavelength, or which of the following waves will have a highest energy or the frequency. So remember that wavelength is inversely proportional to photon energy and frequency, whereas photon energy and frequency are directly proportional. So in this thing, this is an X-ray machine. Okay, so people may confuse between the actual focal spot size and the effective focal spot size. So you have to remember the actual focal spot size is 1 into 3 mm, whereas effective focal spot size is 1 into 1 mm. So remember, actual focal spot size 1 into 3 mm, whereas effective focal spot it is 1 into 1 mm. And there is an important angulation here, that is 20 degrees. Okay, so to attain an effective focal spot, this target is aligned or inclined about 20 degrees to the central ray. Okay, so the numericals you have to remember are actual focal spot, that is 1 into 3 mm, effective focal spot, that is 1 into 1 mm, and the target inclination will be of your 20 degrees. So in this slide, the 4 important things you have to remember are high atomic number, high melting point, and high thermal conductivity and low vapor pressure. So these 4 points and the numericals regarding this 4 points are important regarding the tungsten target. Okay, so and these are the reasons high atomic, why why high atomic number is used. This is because it produces the more number of X-rays. And why high melting point is used, it is because to prevent the melting of anode as high heat is generated at the anode. Okay, then why high thermal conductivity is used, this is because to dissipate the heat in the copper stem. And one more, the final important point is why it has a low vapor pressure, this is because it to maintain the vacuum in the tube. So you have to remember these 4 points and the 4 reasons for the points. So this is a summary of quantities and units. Among them, absorbed dose and equivalent dose are very important. Okay, absorbed dose is nothing but total energy absorbed by a mass, whereas equivalent dose, it shows the biological effectiveness of a radiation type. So remember biological effectiveness for the equivalent dose. And the units, that is SI unit and the traditional unit are important, whereas for SI unit for absorbed dose is Gray and the SI unit for the equivalent dose is Sievert. If you take the traditional unit, the absorbed dose has a rad and the equivalent dose has rem. So these 2 units, SI unit and traditional units, are important. So if you take the radiology, there are two types of effects in the radiation exposure. Okay, so the first effect will be of your deterministic effect and the stochastic effect. And before going into this effect, there are two numericals you have to remember, that is 1/3 and 2/3. Okay, so the complete radiation exposure or ionization of 1/3 effects will be of your direct effects, whereas 2/3 effects or your indirect effects. 2/3 indirect effects are nothing but you will see the hydrolysis of water, which is also called as radiolysis of water. Now if you take the deterministic effects and stochastic effects, here the examples are very important. Okay, to remember in an easy way, all the carcinomas belongs to the stochastic effects, that is all the carcinomas or all the genetic defects comes under the stochastic effects, like leukemias, thyroid cancers, salivary gland tumors and heritable disorders. These are the examples. Okay, if you take the deterministic effect, all the radiation therapy effects or the radiation therapy side effects comes under the deterministic effects. If you take the examples, it includes xerostomia, osteoradionecrosis, cataracts and defective in fetal development. Okay, all these are the examples of deterministic effects. And the cell death is seen in deterministic effect, whereas gene mutation it is seen in the stochastic effect. So these are the important points you have to make a note. Coming to the cell cycle, they can ask you like which is the most radiosensitive phase or which is the least radiosensitive phase. If you take, cells are most radiosensitive in the G2 phase, okay, whereas they are sensitive in the G1 phase. And if you take the least sensitive, cells are in the later part of the S phase. Okay, remember these 3 points: most sensitive in the G2 phase, sensitive in the G1 phase and least sensitive in the later part of the S phase. And this is a very important table which they can ask you in a ascending order or a descending order, that is it includes like high radiosensitivity to low radiosensitivity. Okay, for you the important thing is basal cells of oral mucous membrane comes under highly radiosensitive cells, and you have to note down all other examples also, all other cells which comes under high, intermediate and low radiosensitivity. But if you take this high radiosensitivity, cells of basal cells of oral mucous membrane comes under this high radiosensitivity. Okay, and one more important thing for us is acinar and ductal salivary gland cells. Okay, acinar and ductal salivary gland cells comes under the intermediate radiosensitivity. And erythrocytes, which is a one important thing, which comes under the low radiosensitivity. Okay, so this is a flow chart or a table given here, includes effective dose of various intraoral radiographs. Okay, so here you can note down these numericals, and for example if you take the rectangular collimation, effective dose will be less when compared with the round collimator. So from this you can note that the round collimation will have increased effective dose. And here this is the effective dose for the extraoral radiographs. For us it is important, like panoramic it is 9 to 24 and cephalometric it is 2 to 6. Okay, so and again the plain films like skull radiographs, the effective dose will be 70. Okay, and if you take here the cone beam CT, which is advanced radiographic technique, it has two things here, that is three things here, that is large field of view, medium and small field of view. Okay, so the large field of view will have a high effective dose when compared with the medium and small field of view. So these are the important numericals given for the effective dose of extraoral radiographs. So here the filtration is given. So based upon the kVp used in the X-ray machine, the filter diameter is kept. Okay, so if you take here, if we use a below 50 kVp, the filter used aluminium diameter will be of 0.3 to 0.5 mm. Okay, if you take 50 to 70 kVp, then it will be 1.2 to 0.5 mm of aluminium. And if you take above 70 kVp, then will be of 2.1 to 4.1 mm of aluminium. Okay, and in this picture it is clearly shown the difference between the collimator and the filter. If you see the collimator here, it is restricting the size of X-ray beam, okay, but if you take the filter here, it is filtering all the low energy photons. That means it will get back only the photons which are useful for the X-ray diagnosing. And one more important thing here, it is the film speed, okay. You have to remember the units for the speed is reciprocal Roentgens, okay. So if you take, they can give in the increasing order or decreasing order. The radiographic film speed of D is of 14 to 27.9 reverse reciprocal Roentgens, E is 28 to 50.9 reciprocal Roentgens, and F will be of 56 to 111.9 reciprocal Roentgens. So this is the range of film speed for various D, E and F. So coming to the intensifying screens, there are two types of intensifying screens, that is green emission and blue and ultraviolet emission, okay. So if you take the phosphors which are present in the blue emission, they are gadolinium oxysulfide and terbium activated, okay. These two are used in the green emission intensifying screens, whereas if you take the blue and ultraviolet intensifying screens, they phosphors used are yttrium tantalite and niobium which are niobium activated. So these are two important things you have to remember regarding intensifying screens. These are the various processing temperatures given here and the developing time. So if the temperature is 68 degree Fahrenheit, the development time will be of 5 minutes. Whereas 70, it is 4.5 minutes. 72, it is 4 minutes. 76, it is 3 minutes. And 80, it is 2.5 minutes. So you can see here, if the temperature is increasing, the development time is decreasing. So these are the various processing temperatures given here. And this is the angulation process which is used in the bisecting angle technique. So this for maxilla, for incisors it is plus 40 degrees, for canines it is plus 45, for premolars plus 30, and for molars plus 20, okay. So for mandible it is minus 15, minus 20 for canines, and minus 10 for the premolars, and minus 5 for the molars. So these are the angulations which are used in our daily routine bisecting angle technique. So coming to a few conventional extraoral views which are important. So this is PA Waters view. So you have to, in conventional extraoral techniques, you have to know the view and where it is used, okay. So here in PA Waters view, you can see that angulation is 37 degrees, and this is mostly useful for the examination of the sinuses, that too maxillary sinus, okay. Now we'll see the radiographic picture of Waters view. So they can ask the picture based diagram also, like what is the view given here, okay. So this is a Waters view, and we can evaluate or examine the sinuses in this Waters view. Next, coming to the mandible view, PA mandible, okay. So you can see that the forehead and the nose are touching to the extraoral cassette. So why this PA mandible view is used? So mostly we will see the radiographic thing here, radiographic film view. So this is a PA mandible view, and this PA mandible view is mostly useful in examination or evaluation of the mandibular malformations, okay. The malformations or the increased or decreased size of mandible affect hypoplasia of the mandible or increased size of the mandible. All these things affecting the mandible are seen or evaluated by using this PA mandible view. And one more thing, in the PA mandible view, you cannot examine the incisors, mandibular lower incisors or maxillary incisors. This is because of, you can see here, this is because of the shadow of the cervical spine. Next, coming to, this is a rotated PA mandible view, and the most common thing which can be evaluated on this rotated PA mandible view is your salivary gland that to parotid gland caliculi. Okay, so that this is the radiographic view of PA mandible view, which is it can be taken on only the affected side. Okay, if you have a doubt that patient has a salivary or a parotid gland caliculi on the right side, you can go this view on for the right side. Okay, this is the radiographic view of the PA rotated PA mandible and mostly useful for evaluating the parotid gland caliculi. And this is a submental vertex view. You can see that it is this central ray is passing from the mental region, submental region to the vertex. Okay, and the angulation here is 5 degrees. And why this submental vertex projection is used? Mainly to evaluate the base of the skull. So if you see here, this is the radiographic view of the submental vertex projection. So the base of the skull is seen here, and also the lesions, expansile lesions which are present in the maxilla can also be evaluated by this submental vertex projection. So base of the skull and the expansile lesions in the maxilla or perforations in the maxilla, and even you can see the fractures of the mandible, condyle region or the body region. Okay, and here the radiographic picture of a jug handle view is given. So this jug handle view, it is a modification. That means the patient position is same as that of the submental vertex projection. Hence it is called as a modification of submental vertex view. If you see here, the most common evaluation is our zygomatic arches. Okay, so in this jug handle view, two important things are, it is the modification of submental vertex view, only the exposure is reduced, remaining the patient position everything will be same. And one more thing, there will be useful for the evaluation of zygomatic arches. And this is a reverse Townes view. Only the forehead is touching to the extraoral cassette and the angulation here is 30 degrees. So this is the reverse Townes view, and the important evaluation point in this reverse Townes view will be of here condylar fractures. Okay, so condylar head fractures can be evaluated easily on this reverse Townes view. So here there are a list of extraoral radiographic views given here for the sinuses. Okay, now we will see how they are useful. So the frontal sinus mostly can be evaluated by using a standard occipitomental view or a PA skull view or a true lateral skull, tomography and a CT scan. So all these are the radiographic views which are useful for evaluating the frontal. And if you take the sphenoidal sinuses, the views which are evaluating sphenoidal sinuses include standard occipitomental with patient's mouth open. This is a very important point. Then true lateral skull, submental vertex, tomography and CT. All these views are useful for evaluating the sphenoidal sinus. And if you take the ethmoidal sinus, standard occipitomental, 30 degree occipitomental, true lateral, PA skull, tomography and CT. All these views are useful for evaluating the ethmoidal sinuses. So this is very important. So here the sinuses and the important radiographic views are given. If you take the fracture site, so for each fracture site there is one important radiographic view which is very useful. So here few fracture sites and the radiographic views are given. Okay, if you take the angle, the OPG and lateral oblique are very useful. And if you take the condylar neck, as we dealt, reverse Townes is very important. Other than the reverse Townes, OPG, lateral oblique, transorbital are also used. Okay, then body of the mandible can be viewed on OPG, lateral oblique, PA mandible, periapical. Even the periapical radiographs of involving teeth can also be used for evaluating the body fractures. And the canine regions, OPG, lateral oblique, periapical of involved teeth and true lateral skull. So these are the radiographic views for the canine region. And if you take the symphysis region, that is lower true occlusal, lower anterior topographic occlusal. These two are the important radiographic views for the symphysis region. And if you take the ramus region, OPG, lateral oblique view and the PA mandible view. Okay, these three views are important for evaluating the ramus of the mandible. And finally the coronoid process, which is very important. So coronoid process can be radiographic fracture site can be viewed by using OPG, lateral oblique and standard occipitomental view. So these are the fracture sites and these are the radiographic views which are useful in evaluation. Coming to the TMJ joint, okay, so the lateral aspect of the TMJ joint is mostly seen on the transcranial conventional radiograph, that is transcranial TMJ view. If you take the medial aspect, it is visible on the transpharyngeal. So people might confuse between this lateral and medial aspect of the TMJ. So remember, lateral aspect is transcranial, whereas the medial aspect is transpharyngeal. If you see the OPG, you can see the lateral view of both the condylar heads. Okay, and if you take the reverse Townes view, the condylar fractures, and that is neck, both condylar head and neck fractures can be easily evaluated, and this is for the posterior view. And if you take the transorbital view, it is the anterior view of condylar head and neck. Then tomography, in tomography we can see the all aspects of the joint. Okay, so these are the radiographic views and these are the area of the joint seen on the radiography. So in this important thing, you have to see where you can see the lateral aspect of the TMJ and where you can see the medial aspect of the TMJ. Coming to the CT number, these are the Houndsfield units or the CT numbers, okay, and for the bone it is plus 400 to plus 1000, whereas for the soft tissue it is plus 40 to 80, and the water is important because the Houndsfield unit of water is 0, and for the fat it is minus 60 to minus 100, for the lung it is minus 400 to minus 600, and for the air again it is important, it is minus 1000. So you have to remember the Houndsfield units of each and tissue. So they can ask you in the increasing order or a decreasing order type of questions. Coming to the MRI. So the one point you have to remember in the MRI is how to differentiate between the T1 and T2 weighted images. Okay, so better to remember regarding CSF. Okay, you can see here that this is a T1 weighted and this is a T2 weighted. Okay, in T2 weighted image the CSF will be bright, okay, whereas in the T1 weighted the CSF will be dark. Okay, remember these 2 points. In the T2 weighted it is CSF is bright, and whereas in the T1 weighted the CSF is dark. And one more important thing you can also remember, that is regarding the fat. Okay, fat appearance will be opposite to the CSF, that is fat will be dark on T2 whereas fat will be bright on T1. As you can see that fat is bright on T1. So these are the important things you have to remember in T1 and T2 weighted images of MRI. Now coming to few radiological appearances, important. So the bull's eye appearance, okay, you can see here this is a bull's eye type of or a targetite type of appearance which is seen in the dilaceration. So in the dilaceration bull's eye appearance is seen. Now if you see the teardrop appearance, okay, you can see here in the pulpal region there is a teardrop appearance. Okay, so this is an important radiographic feature of dens invaginatus. So bull's eye is seen in the dilaceration and the teardrop shaped appearance is seen in the dens invaginatus. Now coming to the thistle tube appearance, okay, if you see the pulp chambers, they will have a thistle tube of type of appearance. Okay, this is a characteristic type of appearance in the dentin dysplasias, and you can see in the regional odontodysplasia, the radiographic feature is ghost-like appearance. You can see here the pulpal chambers are in different sizes and giving an asymmetrical appearance or a ghost-like of appearance. Okay, so the tissue tube appearance is seen in dental dysplasia, whereas ghost-like appearance is seen in the regional odontodysplasia. Coming to the fractures. So here this is an Waters view, okay, and this is a coronal CT. You can see here there is a hanging drop of sign. This is the muscle of the orbital region because of the blowout or the orbital fractures. You can see the muscle in a hanging drop sign, or here you can see it is in the form of a trapdoor effect. Okay, so the hanging drop sign or a trapdoor sign is seen in blowout orbital fractures. Now coming to few radiological features of TMJ disorders. So the condylar hypoplasia. Okay, in the condylar hypoplasia you can see the inverted L shape condyle in condylar hypoplasia. And if you take the bifid condyle, in bifid condyle you can see the heart shaped outline. So where do you see the condyle in a heart shaped outline? This is in bifid condyle. And one more thing, this is an MRI picture given here. So the bow tie appearance, this is a bow tie appearance. Where do you see the bow tie appearance is seen in the disc displacement. Okay, so the condylar hypoplasia will have an inverted L shape, bifid condyle will have a heart shaped outline, and the disc displacement will have a bow tie shaped. Characteristic features of TMJ disorders. Now coming to the degenerative disease. Okay, so here the joint mice. Okay, this is because of osteocytes will float in this space of the joint. Okay, so this is because of osteophytes in the joint space, which gives a joint mice appearance. Okay, so joint mice appearance is seen in the degenerative joint disease. And if you take the pencil shaped condyle, okay, pencil shaped condyle is seen in the rheumatoid arthritis. Remember, degenerative joint disease, it is joint mice appearance, whereas rheumatoid arthritis, it is a sharpened pencil appearance. Coming to few soft tissue calcifications. Okay, you can see here this calcified lymph node chaining. So these are the lymph nodes which are calcified and which are appears as a chaining. So the calcified lymph node chaining is a soft tissue calcification. And where do you see this type of lymph node calcifications? Mostly in the granulomatous disorders. Okay, so you will see this type of lymph node chaining in the granulomatous disorders, and the most common example for this lymph node calcifications will be of here tuberculosis, which mostly common cervical lymph nodes will undergo calcification. Okay, so this is regarding the calcified lymph nodes. And if you take here, there is a pipe stem or a tram track appearance. Okay, this is the calcification of an artery. So this is known as Monkenberg's medial calcinosis. Okay, Monkenberg's medial calcinosis will have a pipe stem or a tram track like of appearance because of the calcification of arteries. One more thing, that is a tramline appearance. You can see here, this is a tramline type of appearance. So the tramline type of appearance is seen in Sturge-Weber syndrome. Whereas phlebolytes, okay, so the phlebolytes will have a bullseye. You can see here a eye with an targetide appearance. Okay, these type of appearances will be seen in the phlebolytes. So these also these comes under the soft tissue calcifications. Okay, Sturge-Weber syndrome will have a tramline type of calcification, whereas a phlebolyte will have a bull's eye or a targetide type of appearance. Okay, these are very important in radiological picture based questions. Coming to the onion peel appearance, you can see here the cortical bone. So if first you have to know about the periosteal reactions. Okay, so in this pictures there are two types of periosteal reactions. Other than these two, there are many other periosteal, but here if you take this picture, this is a onion peel appearance, and this onion peel appearance is also a periosteal reaction, and here a sun ray or a sunburst appearance. Okay, this is also a periosteal reaction. So this periosteal reaction of bone formation of onion peel or sun ray is most commonly seen in a osteosarcoma or a Ewing's sarcoma. So here, coming to the periosteal reactions, there are two types of periosteal reactions given here, that is the onion peel appearance and the sun ray or sunburst appearance. And this onion peel and sun ray or sunburst appearance are most commonly seen in the osteosarcoma or a Ewing's sarcoma. Coming to the absence of lamina dura, you can see here there is an absence of lamina dura, and this type of absence of lamina dura is most commonly seen in hypoparathyroidism, Paget's disease and hypophosphatemia. So you have to remember these three disorders where there is an absence of lamina dura. And coming to the cotton wool type of appearance, you can see here the cotton wool type of appearance, important radiographic picture based question, and this type of cotton wool appearance you can see in Paget's disease, in fibrous dysplasias and in the cemento-osseous dysplasia. So in these dysplasias you can see the cotton wool appearance. Coming to the ground glass appearance, you can see here it is a ground glass appearance of the cortical bone, and this ground glass appearance you can see the fibrous dysplasia, Paget's disease, hypoparathyroidism, ossifying fibroma and sickle cell anemia. Okay, remember these important diseases of 5 which you can see the ground glass appearance, which is nothing but the rarefaction of the bone. Okay, so this rarefaction of the ground glass appearance can be seen in these 5 type of disorders. So here there is, you can see the punched out radiolucences. Okay, the punched out radiolucences are seen in multiple myeloma. Very important picture based question. Now coming to these are the IOPAs which of sickle cell anemia. Okay, so in sickle cell anemia you can see the step ladder pattern. Okay, you can see here this step ladder pattern is a radiographic on IOPA. Okay, on IOPA step ladder pattern is a characteristic feature of sickle cell anemia. It is very important point. Then the widening of the pedial space. Okay, there are various conditions you can see where there is a widening of pedial space, but for us the apical periodontitis is very important. You can see this here, the widening pedial space, scleroderma and trauma from occlusion. Okay, so this is scleroderma is very important to be noted. So in scleroderma you can see because widening of pedial space, and apical periodontitis everyone knows, so concentrate on the scleroderma.